Multiple Myeloma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Multiple Myeloma Hub podcast. Today we'll be hearing from Roberto Mina from the University of Turin in Italy and Andrzej Jakubowiak from the University of Chicago in the US.
Hello, I'm here with Dr. Roberto Mina, and my name is Andrzej Jakubowiak, and we will discuss today pros and cons of using bispecific antibodies in treatment of multiple myeloma. Maybe brief introduction. I'm Andrzej Jakubowiak. I am Professor of Medicine and Director of Myeloma Program at the University of Chicago. And Roberto, can you introduce yourself?
Professor. Thank you, Professor Jakubowiak. My name is Roberto Mina. I'm a hematologist and assistant professor at the University of Turin, Italy.
And we are both involved and have been presenting respectively abstracts at recent meetings, including at ASCO 2022, in which array of reports and updates of using bispecific antibodies in relapsed refractory myeloma was included. I may start that I was a presenter of an update from phase 1 MajesTEC trial with elranatamab, bispecific antibody being developed by Pfizer. And Roberto?
Yeah, I discussed during the ASCO meeting, I presented a positive discussion because there's a lot of data out there, lots of trials that have been presented at the meeting on bispecific antibodies, and the field is becoming pretty crowded. As a matter of fact, elranatamab is one of the bispecific antibodies targeting BCMA that Dr. Jakubowiak presented, and he may give us an insight on the results presented. But there are also other bispecific antibodies targeting the same agent, such as BCMA, or alternative targets such as talquetamab or cevostamab targeting GPRC5D or FCRH5. And I believe there are a lot of, the data are promising. I wouldn't probably say pros and cons, but maybe more promises and challenges for the use of bispecific antibodies. We have seen results that have not probably never been reported with a single agent drug, except for CAR-T. Those results in terms of responses particularly are pretty close to those reported with CAR-T. But we know also that the management of these patients in terms of safety and also logistics can be an issue, and we have to learn how to manage it. So maybe Dr. Jakubowiak, you want to briefly summarize the results from the MagnetisMM-1 study?
Yep, and which was also presented at ASCO, a poster discussion. And maybe I will introduce a brief comment, which we probably owe you at the beginning. I'm sure you all know what bispecifics are. So these are treatments which have been recently developed with broad spectrum immunotherapy of multiple myeloma, in which off the shelf, so ready to use when patient is ready to be treated, constructs which sometimes are called BiTEs, although there is a little bit of a difference, or T-cell engagers, have ability to engage with target. For the most part, the target was BCMA, like for most CAR-Ts. But as Roberto mentioned, another target in advanced development is GPRC5D. And at the same time, engagement of T cells through CD3. So the main advantage of this approach, before we go into some of the details of efficacy, is that it is off the shelf, as we say. It's readily available to be used. And maybe another theme when we talk about maybe major features and distinguishing them from CAR-Ts, which came earlier in development, is slightly lower, or definitely lower rates of toxicities, which are typically associated with immunotherapies, CRS, cytokine release syndrome, and other toxicities are observed in bispecific treatments, but they are less commonly occurring and with lower grades than with CAR T therapies. That hopefully sets the stage, and I'll just briefly summarize main findings from MajesTEC trial. I presented MajesTEC-1, but there was also a oral session, MajesTEC-3, both showing results of treatment with elranatamab, and in both studies showing very comparable toxicities, efficacy, which was ranging in 60 to 64% between those two studies, high rates of complete responses, 35, and high rates of VGPR approaching high 50s. In addition, the study which I presented included 13 patients previously treated with BCMA targeting therapies like ADCs and CAR Ts or both, and showed remarkably, I think, and is one of the major findings from these meetings, very comparable response rates to BCMA naive as far as treatment patients, and maybe slightly lower, but not statistically differently, considering the size of the sample was small, but we can make this statement. I hope, Roberto, you would agree. And I would add that these results on a smaller sample size correlated with what was presented also at poster discussion for teclistamab. And you can take over, Roberto.
Yeah, sure. So I think that the data that have been presented at the ASCO are about bispecific antibodies open up a wide number of considerations. The first is, as you mentioned, there's a high efficacy with 2/3 of patients responding, 1/3 of patients achieving a complete remission in a very heavily pretreated population, something that beyond CAR T we're not used to. And so this is a great point, very promising efficacy. The second point is, as we now have different anti-BCMA targeting strategies, one question is, how can we use them? Are they alternative strategies? Can we sequence them? And what you have pointed out is extremely important. So we have seen with bispecific antibodies activity, even in patients that were treated previously with an anti-BCMA, ADC, or CAR T. And this somehow allows us to think about a retreatment or a sequencing treatment. And this is particularly important also because we also have alternative targets, as I mentioned before. So we don't want to waste drugs, but we don't want to also use a drug that may be suboptimal. But the results in previously BCMA exposed agent for elranatamab, for teclistamab, and for talquetamab, so using a different antigen, are very, very similar. And the activity seems to be pretty close to the one observed in patients without a prior exposure to BCMA. So this allows us to think that we can use these different strategies targeting the same antigen in a sequence rather than in an alternative way. So in terms of efficacy, I believe that there's no doubt that this agent will fill the gap and a medical need of patients with triple class or pentaclass refractory, and potentially also changing the landscape in earlier lines. We also have some, I wouldn't say cons, but probably rather some challenges to address, because as you mentioned, the safety profile is significantly improved as compared to CAR T cells. The rate of CRS is still pretty high, ranging in the range of 70-75% of patients, but the grades are mostly grade 1 or grade 2, without significant number of grade 3 events or grade 4, and also the neurotoxicity seems much inferior and infrequent as compared to CAR T cells. Still, patients need to be hospitalized for the step-up doses, although there are attempts to, in order to administer these drugs in an outpatient setting. But so this is an issue that we need to address somehow. because of course hospitalization may, particularly in some countries where there's not a huge availability of beds in the hospital, may represent a barrier for patients to receive these drugs. I believe that the data you presented about the in the MagnetisM study with the step-up doses and the priming with the pre-medication with steroids are important to mitigate, as you showed, the risk of CRS. And so I believe that there are these challenges that we can address in order to deliver this kind of drug that are seems very, very potent. What do you think about this?
I completely agree, and we are giving you away some of the highlights of what we have learned from bispecific antibodies. And those highlights you've heard were efficacy in 60 to 70% range, complete responses in 30 to 40% range, already advanced development of multiple BCMA targeting bispecifics. In addition to ranatamab and teclistamab, there are 3 or 4 lead other candidates in this space targeting BCMA and other targets. And off the shelf, as I mentioned, lower rates of CRS. So these are pros. And clearly, if you would not have CAR Ts, looking amazing compared to what we had in our armamentarium tool for relapse and refractory myeloma. I think if I would take the subject of our meeting and to start maybe putting my commentary on pros and cons of bispecifics, you've heard pros, you've heard a little bit of cons, that indeed there is a need for admission initially for first priming doses for the most part, for most of those constructs. But then this goes away as patients fairly quickly are moving to outpatient, and for the most part either weekly or every 2-week treatment, which in subsequent treatments is for the most part very well tolerated with very limited risk of development and other CRS toxicities. I want to mention that in talquetamab, the specific other than CRS toxicity is related to targeting the mucosa and mucositis and dry mouth and some issues related to that. But for the most part, they are better tolerated than CAR T. So these are the pros. If I would say cons from my end compared to CAR Ts, and we have to say that we are going into adventure here because there is no direct comparison. So we're just comparing the results of studies in similar patient population, but not identical. But still, if one would look at, for example, efficacy of top CAR Ts targeting BCMA, and now also GPRC5D as presented at this ASCO, they reach close to 100% response rate and even over 80% of complete responses. And that is definitely con for BCMA and other targeted bispecifics. But I would add maybe my own, to some extent, maybe considered controversial comment that in CAR Ts, we are a little bit differently reporting efficacy as for CAR T therapy. To get to treatment, the patient needs to have cells procured, collected in leukapheresis procedure, and for most CAR T constructs, relatively long 4 to 6 week period of time of production of CAR Ts, and patients who do not make to the treatment are not included in those analyses. So we would include them on intent to treat from the moment when patients are consented into the treatment. Maybe those efficacy differences would be not as pronounced as we can see them. So that one efficacy superiority of CAR Ts may not be as apparent. We have clearly more data on CAR Ts in terms of longevity of response, which now for some of the constructs is after 2-year follow-up much more mature. And we have, for example, for cilta-cel, more than 50% of patients still progression-free at 2 years. For bispecific, we have very promising looking, but probably not yet mature enough to really determine where this will end up, but maybe closer to 1 year, what it appears to be progression survival. So it's a little bit also on this end, efficacy inferiority. But again, it is on different type of presentation of the data, so may not necessarily be as different as it appears to be. So in my opinion, there is a lot of pros, and I think I would add to pros also the fact that we have more data for bispecifics, both by elranatamab and teclistamab, that they are effective in sequence after previously BCMA targeted therapy with CAR Ts or bispecifics or ADCs or both, or even 2 agents at the same time. So that's my take on pros and cons. Roberto, can you challenge me or make your own comment?
No, I agree with you. And I think an important point is that the results with CAR Ts, particularly with cilta-cel, are clearly higher for patients who can get the CAR T. The question, as you mentioned, and I agree with you, is can you get the CAR T? So to me now, bispecific antibodies place themselves kind of in between ADCs and CAR Ts. Probably as compared to CAR Ts, they give up a little bit of efficacy. We certainly have higher CR rates with cilta-cel, for example, and probably longer PFS, but there are a lot of challenges with CAR T, particularly in heavily pretreated patients. Manufacturing time, patient with a rapidly progressing disease and may be prevented from actually get the treatment, while with bispecifics are off the shelf, and still probably the efficacy is a little bit lower, but it's an off-the-shelf product, and also patient rapidly progressive or with a high-risk disease can be treated in a timely manner. And and this is just with a single agent drug. I think they can probably also be boosted with some other drugs. We saw some presentations at ASCO and also HIHA with a combination of teclistamab and talquetamab with daratumumab, potentially harnessing the efficacy of both bispecific antibodies by downregulating B and T regulatory cells. And we saw brilliant responses on a number of a bunch of patients. So still, it's early to actually say if this it will be translated into a clinical benefit, but still there is a potential for combination with this with bispecific antibodies with currently established standard of care. One thing that I would point out as a potential challenge is the risk of infection, which we have seen with CAR Ts, and we'll probably see also with bispecific antibodies, particularly when as they are administered until progression. And this is something that we need to carefully monitor and look for. But I think they are a good platform also for combination and to be moved in early lines as some clinical trials are doing. So I agree with you. I think there's a lot to know, a lot to explore, but I think the premises are very, very good.
And I would like to echo and very much agree with your two maybe points of your comment, which I was about to make as well. Indeed, one of the pros on bispecific is that it's probably going to be easier to figure out combinations, and they are already showing promising results. Randomized study which evaluates teclistamab with daratumumab, very promising looking combination with response rate probably exceeding 80% and higher CR rates, so appears to be better than single agent, is in phase 3 evaluation, and that will generate very important results. It would be worth stressing again what you just said, that bispecific and CAR-Ts have been associated with increased risk of certain infections, including those which we worry most, including for PJP or other infections related to viruses, including maybe a very high risk of more difficult management of viral infection, including COVID, with some deaths reported in some studies and higher than expected numbers. So these are the challenges for both, I think. But I think that I would stress that efficacy of bispecific, while seemingly inferior to CAR-T, is looking promising, particularly in combinations. And we may have more room to evaluating those combinations as we move forward. So I think that there is a lot of promise related to this treatment. On a con side, as I have managed a lot of patients treated with CAR-T, including those with cilta-cel, it is so good feeling for the patient, but also for the doctor, to have a patient who had received one-time treatment and after maybe a little bit higher rate of toxicities is discharged home, and for the next 2-3 plus years is without treatment and living normal life with normal counts without any evidence of disease. With bispecific, we would likely need to, maybe for a fixed period of time, but have a more extended treatment. So it is more of a traditional type of therapy of multiple myeloma. Do you agree, Roberto?
Absolutely. Our experience with CAR-T is at one shot and then following the patient just for follow-up visits is something that we have never experienced in myeloma, and patients are enjoying it very much. Also, one thing I believe is that now bispecific antibodies are used as an until progression treatment. Maybe there will be some room to explore their use as they're used in other diseases as a fixed duration therapy in order to maximize their efficacy and use in the best way the immune system, while not using them until progression, also minimizing risk of infection and potentially using MRD to drive their use. This is just a speculation, of course, but I think it's something that may be worth exploring in the future.
And I'm sure it will be advised not only by what we think is the right duration of treatment, and you made a good point that not only to limit toxicities and infection, but also to limit exhaustion of immune system, to give the time for its recovery after we stop it. But there is a good possibility that we will be guided for the duration of treatment by depth of response, including MRD negativity. These are the challenges which we need to take and resolve, but I'm sure they will be giving us answers in upcoming meetings. I think you may, if you don't mind, Roberto, try to wrap up. It's by no means enough time to cover everything what we can discuss about pros and cons of bispecifics and multiple myeloma. I would put you maybe on the spot and will ask you, you have a patient who is relapse refractory. You have already approved or on trial available both bispecific targeting BCMA and CAR-T. What would you pick first?
I would use a CAR-T first, also because I think that collecting cells potentially after a bispecific might not be the best thing to do, especially if this is done sequentially. But in terms of efficacy, if the patient is fit enough to receive a CAR-T cell, I would use CAR-T cell, and I will use bispecific at relapse. But I also believe that probably the majority of myeloma patients, being a disease of the elderly, might actually be a candidate for bispecifics and maybe not for CAR T cells. So I think that overall, the message is that we have a lot of agents. We just need to learn who is the best patient for what, and it's great to have such a possibility of choice. What is your thought about your question?
Similarly, and to this, until we got the first 2 CAR Ts approved and available, we were limited with these choices by eligibility criteria, and most of these clinical trials excluded previous BCMA targeted therapies, and we have been prioritizing CAR Ts and still prefer, for the reasons which you just said, CAR Ts. And I would add to that we have less data on treatment with BCMA targeted CAR Ts after BCMA. In fact, we have almost no data at this point. On the other hand, bispecifics generate, as we discussed, some data that they can be efficacious. So in a way, we have also data-supported reasoning for prioritizing CAR Ts ahead of bispecifics, as we know that bispecific may be efficacious after CAR T relapses. That makes me even more inclined to go there, but there will be patient preferences. There will be patient who is maybe more frail, on higher risk of toxicities with CAR Ts, which are, as we said, more likely to generate higher grade of toxicities during the initial admission than bispecifics. So these will be eventually choices, but my prediction is that in real life, we probably will see more use of bispecific than CAR Ts for a variety of reasons, including it will be probably available to all oncologists, whereas CAR Ts may be mostly used in specialized centers. Do you agree?
I totally agree. I think in the community setting, this will make the difference.
Yeah. I think it's exciting time, if I may wrap up from my end, to discuss bispecifics in the context of other therapies. I think that we didn't say the last word about them. I think the important thing is that both CAR Ts and bispecifics are moving to earlier lines of therapy, and there will be a lot of amazing data as we anticipate that it might be more efficacious there. So a lot of things to follow, and we're happy to share what we know so far at this meeting. I really very much enjoyed talking to you, Roberto. Any thoughts from your end to close?
I cannot but agree with you and what everything has been said so far. The last word is not said, and I think there's a lot to improve, but still a lot of potential. I really enjoyed this discussion on bispecifics and CAR Ts, and thank you.
Thank you very much, everybody.
Thank you for listening to the Multiple Myeloma Hub podcast. We would also like to thank our supporters, Pfizer, AbbVie, Bristol Myers Squibb, Genentech, Roche, Amgen, and Takeda.
Multiple Myeloma Hub podcasts, brought to you by